The House Health Policy Committee will come to order. Will the clerk please take attendance?
Chair Vanderwall.
Present.
Representatives Thompson.
Present.
Meerman. Tisdale.
Here.
Bierlein.
Here.
DeBoer.
Here.
Preston.
Yep.
Schmaltz.
Here.
St. Germain.
Here.
Bonak.
Here.
Frisbee. Witsit. Carter.
Here.
Whitwer.
Here.
Neely.
Here.
Hoskins. Foreman. Mr. Chair, you have 12 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Bonak moves to adopt the minutes from the February 18 meeting. There being no objection, the motion passes. Today we are going to hear testimony on two bills as well as vote out our bill from last week. We're going to begin with Senate Bill 398, and I believe it is from Senator Bellino, and his staffer is here. Welcome, my man. And as you know, you've got the button. The testimony table is yours. It is bill number 398.
Thanks, Chair Vanderwall and members of the committee. Thank you for the opportunity to testify to Senate Bill 398, sponsored by my boss, Senator Bellino. Senate Bill 398 is a regulatory modernization bill. It directs LARA to revise Michigan's rules governing opioid treatment programs, or OTPs. The only facilities authorized to dispense methadone for opioid use disorder. This legislation aligns Michigan's regulations with federal standards and removes state-level barriers that exceed evidence-based requirements. Specifically, this bill remove restrictions on applications for mobile OTP units, improving geographic access. It eliminates the one-year history requirement for admission so that diagnosis is based on clinical criteria, not an arbitrary timeline. It permits OTPs to admit and treat minors when clinically appropriate and consistent with existing consent laws. Clarifies that discontinuing medication for opioid use disorder is not a mandated goal of treatment, recognizing that opioid use disorder is a chronic condition. It removes duplicative medical necessity redeterminations for continued treatment, and it prohibits administrative discharge solely for failure to participate in counseling for ancillary services. To be clear, this is not pure deregulation, as federal safeguards governing methadone treatment remain fully in place. What this bill does is it eliminates unnecessary state-specific restrictions that can delay care, interrupt treatment, or increase overdose risk. Medication for opioid use disorder is evidence-based and life-saving. Treatment continuity matters, as arbitrary barriers do not improve safety, they reduce access. The bottom line is this: Senate Bill 398 improves access to comprehensive treatment, supports continuity of care, and ensures that individuals struggling with opioid use disorder in the state of Michigan can receive evidence-based treatment without unnecessary state-imposed obstacles. I respectfully ask for your support. Thank you.
Thank you. Any questions from the committee? Well, you did a great job. Nobody has any questions, but we appreciate you being here. I know we have one other person to testify yet on Zoom, but if you could stick around just in case some questions arise, that would be greatly appreciated.
Absolutely. Thank you.
Thank you. Next up, wishing to speak in support, Andrew Whitaker, Pew Charitable Trust, and I believe he is on Zoom. Is that correct? Here we are. Andrew, the floor is yours.
Good morning. Thank you for the opportunity to testify, Chair Vanderwall, members of the committee. Thanks for holding the hearing, allowing me to testify virtually here from Frankfort, Kentucky. My name is Andrew Whitaker, and I lead the Pew Charitable Trust technical assistance work in the state of Michigan. And I'm testifying in support of Senate Bill 398. The Pew Charitable Trust is a data-driven research and policy organization. Pew's Substance Use Prevention and Treatment Initiative collaborates with states on policy reforms that improve access to timely, comprehensive, evidence-based prevention and treatment for substance use disorders. Pew began its work in Michigan in 2024, which culminated in a policy memo that was delivered in November of that year to members of this committee, the Senate Health Policy Committee, and the executive branch. Those recommendations were developed through extensive stakeholder conversations with experts across Michigan, an analysis of Michigan's current policy landscape in relation to best practices and policy reforms in other states. Pew's also conducted analysis of Michigan's existing treatment providers to identify current treatment gaps and completed Pew-initiated research on the state's OTP regulations compared with federal requirements. And one of the recommendations is found in SB 398, which would improve access for Michiganders to life-saving medications at OTPs. As Mr. Martin talked about, state-level regulations around OTPs, which are the only facilities that can currently provide methadone to treat opioid use disorder, vary widely across the country. Many regulations are not evidence-based and impose burdensome restrictions beyond those required by federal law, which make it more difficult for individuals with opioid use disorder to access and remain in methadone treatment. As seen in a figure that's included in my written testimony, many Michiganders face significant travel burdens to access services at OTPs, with a large segment of the state driving 30 minutes or more to their nearest OTP. Patient-centered care requires access to all forms of FDA-approved medications for opioid use disorder. Since methadone is only accessible at OTPs, regulatory reforms are necessary to ensure patients can access the treatment that they need. In 2021, Pew conducted a national study of OTP regulations that identifies areas where each state's policies are more restrictive than federal requirements. Pew found 5 areas in Michigan's OTP regulations that are more restrictive than federal regulations and could restrict access to treatment, which Mr. Martin laid out, but I'll reiterate here. Restrictions on medication units, a requirement for a 1-year history of opioid use disorder to initiate treatment, age-related restrictions on treatment admission, punitive administrative discharge policies, and discontinuation as a goal of methadone treatment. Senate Bill 398 would require the Department of Licensing and Regulatory Affairs to update its OTP regulations to remove these provisions that lack supporting evidence and impede patient access to treatment for Michiganders. LARA recently finalized revised regulations that reflect these changes, and Pew worked closely with them on those. However, legislation is still needed to codify these important patient-centered reforms. For these reasons, Pew supports Senate Bill 398 and urges the committee to advance the bill. Thank you again for the opportunity to testify, Chairman and members of the committee. I look forward to any questions you might have.
Thank you, Andrew. Appreciate it. Any questions from the committee? I'm not seeing any questions that anybody has. I thank you both for your time and your testimony today, and we look forward to continuing to work with the senator on this bill to make sure we get it done for you. Thank you.
Thank you.
We have a couple other cards to read in. Not wishing to speak in support, Elizabeth Cutter, Michigan Health and Hospital Association. Not wishing to speak in support, Jarrett Scroop, Mackinac Center. All right, moving on. We are going to take a quick vote right now on House Bill 4779, introduced by Representative Wendzel. There is an H1 substitute for this bill, which adds a 1-year implementation period. Representative DeBoer moves to adopt the H1 substitute for House Bill 4779. Clerk, would you please take the roll?
On the motion to adopt the H1, Chair Vanderwall.
Yes.
Representatives Thompson,
Yes.
Mearman,
Yes.
Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins, Foreman.
Yes.
Mr. Chair, you have 15 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. The H1 substitute is adopted. Next up, Representative Tisdale moves to report House Bill 4779 as substituted to the floor with recommendation. Clerk, would you please take the roll?
On the motion to report as sub H1, Chair Vanderwall,
Yes.
Representatives Thompson,
Yes.
Mearman,
No.
Tisdale,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely,
Yes.
Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 15 yea, 1 nay, 0 pass. The motion prevails.
Thank you, Madam Clerk. House Bill 4779 is reported with recommendation. Next up, we're going to take testimony on House Bill 4832, introduced by Representative Preston. Were over 1,000 cards submitted on this bill, and so I don't massacre 999 of the names. We're going to have those available electronically for you. Representative, thank you for being here. Whenever you're ready, the testimony table is yours.
Thank you. 1,000 cards, boy. Good morning, Chair, members of the committee. Appreciate y'all. House Bill 4832 amends the Public Health Code to establish a formal state licensure framework for certified anesthesiologist assistants, CAAs, professionals who already play a valuable role in Michigan's continuity of care. CAAs are graduate-level non-physician anesthesia specialists who hold national certification from the National Commission for the Certification of Anesthesiologist Assistants. To achieve this, they complete bachelor's degrees with rigorous pre-medical coursework followed by 24 to 28-month accredited master's programs in anesthesia, and a national certifying exam and ongoing continuing medical education, typically 50 hours every 2 years, along with periodic reexaminations. Their duties are performed exclusively under the direct supervision and direction of a licensed physician anesthesiologist. Typical responsibilities include obtaining pre-anesthetic health histories and physical exams, ordering and interpreting diagnostic tests, establishing IV access and monitoring lines, preparing and calibrating anesthesia equipment, administering and adjusting anesthetics, adjunct medications, and fluid maintenance, managing airways, maintaining anesthesia levels, continuously monitoring physiologic data, managing emergence and post-anesthesia recovery, participating in emergencies such as CPR and ACLS, which is advanced cardiac life support, and documenting all care. Importantly, CAAs have no independent practice authority or prescribing rights. Every action is delegated by the supervising anesthesiologist. In Michigan, CAAs already practice in operating rooms and perioperative settings across major health systems, primarily in high-volume surgical environments due to supervision requirement. They work in academic centers, community hospitals, ambulatory centers, and occasionally in ICUs or pain clinics. Michigan, like the rest of the country, faces a growing demand for surgical and procedural anesthesia services. Fueled by our aging population, increasing surgical volumes, and overall healthcare capacity pressures. CAAs help address these anesthesia workforce shortages by enabling each anesthesiologist to safely oversee more cases within the anesthesia care team model, improving operating room efficiency, reducing delays, and enhancing patient access without compromising safety. Currently, CAAs practice in Michigan under a general delegatory authority in the Public Health Code. The supervising anesthesiologist must be physically present and immediately available, following the National Anesthesia Care Team model, where the physician designs the plan and remains responsible for the patient's outcome. Without state licensure, there is no protection on who can use this title, no standardized oversight, and no clear regulatory path for anesthesia assistants. Meanwhile, we see real strains, surgery delays, rescheduling at systems across the state, with national shortages rising sharply post-COVID. Sometimes from 35 to 38% in 2020 to 78 to 80% in 2022. So it's egregious. I mean, it's a steep rise over time, and that's per the American Society of Anesthesiologists. These bottlenecks stretch physicians thin, limit throughput, hinder access, and especially hinder it in high-demand areas. 4832 formalizes and standardizes this existing framework without altering supervision requirements or expanding the scope. Under the bill, licensure applicants must complete a board-approved graduate-level CAA program, pass the national standardized exam, and complete a board-approved advanced cardiac life support and pediatric advanced life support certification. The scope of practice is defined but not expanded and includes an explicit list of delegated anesthesia tasks that mirror the current practice, performed only under the anesthesiologist's supervision. Anesthesiologists will still be required to be on-site and available with a maximum 4-to-1 ratio of CAAs to anesthesiologists. This bill reinforces the physician-led anesthesia care team model endorsed by the American Society of Anesthesiologists and the Michigan Society of Anesthesiologists. It provides regulatory certainty, enhances public trust through formal standards, aligns with national credentials, and helps attract and retain these specialists to meet rising demand. In short, 4832 is an incremental step to build Michigan's healthcare workforce amid the shortages that we're currently going through. It shows the state values these professionals' unique contributions and is committed to protecting their work under the law, ultimately benefiting patients through better access and efficiency. Appreciate your consideration, and I'm ready to answer any questions you may have.
Thank you, Representative. Any questions from the committee? I know we have several. Yes, Representative Tisdale.
Thank you, Chair. Representative Preston, help me out a little bit here with a certified anesthesiology or anesthetist assistants cannot or can run a room by themselves?
They're in the room by themselves, but they're under the authority of a anesthesiologist who has a 4-to-1 ratio. So, my clinical aspect when I was in clinics with CRNAs at that time, the physician would come in and literally put eyes on the patient, ask for the protocol that was going to be performed for whatever the surgery or the procedure was, and that anesthesiologist would then sign off on that care approach for that patient. So the anesthesiologist literally, with the 4-to-1 ratio, it's within where it's always been. I mean, 4-to-1 is pretty standardized, and again, they put eyes on the patient
With a CRNA?
With the CRNA back then, yes,
Yes.
And with CAAs now with this iteration. This is a capacity building bill, and
Okay. Do they have to be physically present?
Yes.
Or do they have to be on site?
they're typically in the OR in their office, and before that patient starts, they usually put eyes on that
Do
patient.
they have to be on the OR floor?
I believe so. Yes. Yeah.
Okay. Because there's some
it's
confusion
under the-
here.
they're under the
I can
direct
see where you can
supervision.
leverage to increase capacity. You can leverage CRNAs. They can run a room.
I would tell you that no matter what it is, you can. The direct supervision speaks for itself. That wouldn't stop a physician from, leaving. I mean, that would not be in his best interest or in the patient's best interest. But
Yeah.
so direct supervision, I think, really is self-explanatory.
And on the reimbursements, quite often licensure is an advantage in reimbursements. Mm-hmm. Is that it says, what I'm reading says that they're already recognized by CMS and most major insurers. Is the licensure here also a reimbursement issue to make sure that the hospitals are getting properly reimbursed for the use of these individuals? Or
I don't know if that's the method so much as making sure that they are part of the care team model recognized in Michigan through the licensing process.
yeah, because there are surgical techs and radiology techs
Right.
and all sorts of people running around ORs.
When
that
you're
aren't
talking about this
licensed.
level of care, licensing is important.
Okay.
It's as a paramedic, we dabble in the areas of anesthesia just due to the emergent nature of what we do, and we have a rigorous accreditation that we also have to follow.
It's just, it's that leveraging of educated bodies to expand care. That's what I need some clarification on. So we can continue this
Sounds
at
good.
another time. Thanks.
Yep.
Representative Thompson.
Thank you, Mr. Chair. Thank you, Representative. So I have a few questions, and maybe just if willing, just a little bit of insight thought process. So I know a lot of the confusion lays around the difference between an anesthesiologist assistant and a CRNA. So I know in healthcare, and a lot of people that don't understand, the way you're trained, so anything within nursing, so if you're a certified nurse anesthetist, your model is based on nursing care and on a nursing model within nursing diagnosis, within nursing scopes. Being trained as a physician and a physician's assistant, anesthesiologist, that goes towards a medical model. So I understand, I'm glad within this information here that's showing there's two separate methods for the ideology of the training. What are anesthesiologists going to not be able to do or be able to do should this legislation pass? Is anything going to change what they currently do right now?
I think the biggest thing is recognition of a licensure. That's probably the biggest thing. I don't see much changing other than a licensure recognition. There is no scope aspect in here. They cannot operate independently. They have to, the way the CAA model is set up is they have to operate under the direct supervision of the anesthesiologist.
So currently, they've had the training. They take the exam to become certified. They become employable. They stay under the direction of the anesthesiologist. Something that I have seen within the state of Michigan and what we've been trying to do, you with a healthcare background, I with a healthcare background, is that we are across the board trying to deregulate and get rid of a lot of licenses that we believe as a state are useless and are stopping people from getting into certain fields. But when it comes to healthcare, I with you take the stand that if you are working on someone's life and you have their life in your hands, I believe that you should be licensed to do so. So what do you think the reason for licensing is as a whole? If you were just to look at it, why would people gain license in healthcare?
Maintain standards, maintain their role in the care team, accountability within the system and in the care team that they function within. I mean, it's when you're talking about acute system licensure like this, I think it's incredibly important that the state recognizes that, in order to protect the system. Because a lot of what you and I have been working on is really just capacity building. It's incremental capacity building throughout the system, to try to just improve patient outcomes. Like myself, and I know with yourself, this is all about patient outcome at the end and making sure that people get the best care available.
All right. Thank you. Thank you, Mr. Chair.
Thank you. Representative Frisbee.
Thank you, Chair. Rep. Preston, how long has the AA level been a licensure in the United States?
That one I did not look up, but I'm sure that there'll be somebody coming up behind me that'll be able to answer that
good.
question.
Do you know how many states currently allow AA to operate in the care team model?
16, I believe.
I don't know the number, but I know that there are.
All right. And then I'd like to find out if there's any studies, and I doubt you know these off the top of your head, that are report both positive and negative impacts of AAs in a care team model outside of those maybe provided by AAs or CRNAs. Obviously, there's a little bit of conflict of what they may present. So some independent studies about patient outcomes of which you're trying to make sure that are remaining good. And I think in a care team model, they probably are, but I'd love to see some studies about that.
No, this is the beginning of a conversation, everyone, and I look forward to fleshing a lot of this stuff out. It's been a busy cycle, but
Yeah.
again, capacity building within our healthcare models it's an important thing for our patients. When you have medical students having a hard time finding residencies. I mean, it's just from top down, and you go through the entire healthcare platform, we're seeing strains and stresses throughout the entire system.
Yeah.
So
Thank you.
appreciate the questions, though.
You bet.
See no other questions. Thank you, Representative, and we look forward to the next folks coming up. And just Representative Frisbee, right now, 17 states are currently have licensure. All right, next up, and they're coming up together, is Daniel Maceros, CAA's Michigan Academy, anesthesiologist assistants, and Dr. Jordan Brewer, same. So, guys, thank you for being here. Appreciate it. When you're ready, the testimony table is yours. Just make sure you press the little red button underneath your mic, and you are live. and the floor is all yours.
Thank you, Mr. Chairman Vanderwall and members of the committee. Thank you for having me here. I think we'll be able to answer a lot of the questions that just kind of came up there. Good morning. My name's Danny Masaris. I'm the past president of the American Academy of Anesthesiologist Assistants and also the Michigan Academy of Anesthesiologist Assistants. I am here today in support of HB 4832, and I am representing the 30 CAAs already practicing in Michigan and the more than 4,400 CAAs across the country. Thank you for giving me this time. House Bill 4832 is a simple bill. This is not a scope of practice bill. We are not asking to change anything about our current practice. We will continue to practice under the medical direction or supervision of physician anesthesiologist because that is the safest practice for patients. Certified anesthesiologist assistants are already caring for patients across Michigan in the operating room. However, we lack the licensure. The lack of licensure significantly limits our ability to go across the state. The Michigan Hospital Association supports this bill. The hospital systems across the state need anesthesia providers to meet the growing surgical demand, which is especially true in rural areas. This bill helps accomplish that. CAAs can practice anywhere anesthesiologists are located. This bill is a common sense solution that allows physicians to safely care for more patients by supervising qualified CAAs or CRNAs within the anesthesia care team model. This model results in significantly more health care being delivered than independent practice models, which have not solved rural access challenges in Michigan. CAAs and CRNAs are both recognized by CMS as non-physician anesthetists. Whether care is delivered by a CRNA or a CAA, under the supervision of a physician, there is no increase in cost. CAAs are recognized by Medicare, Medicaid, TRICARE, and all major commercial payers in Michigan. In your packet, or the packet that we will leave behind, you will find a retrospective study from Stanford. It reviews over 440,000 Medicare cases comparing CAA and CRNA practice. That study found no difference in mortality, length of stay, or cost. This data reinforces what we see every day in the operating room. CAAs deliver safe, high-quality care. If Michigan is going to overcome our rural access challenges and surgical backlogs, we must do a better job of retaining talent and recruiting highly educated healthcare professionals. Over the past 2.5 years, we have hosted over 85 student shadowers in our ORs. Many of them from the University of Michigan, Michigan State, Central Michigan, and Grand Valley University. These are talented, motivated students who want to work in Michigan. Yet, they leave the state to attend AA schools in Indiana, Ohio, and Wisconsin, and they do not return because Michigan does not offer licensure, and these states do. We have the opportunity right in front of us to move the needle on access to care. In a few minutes, you will hear arguments framing this as a conflict between providers, that we are going to take their jobs. This is not true. This is not us versus them. We work alongside CRNAs every day, and we need more of both providers. In fact, many of the voices opposing this bill today have previously argued that Michigan needs more providers to meet demand and improve access. Licensure for CAAs accomplishes exactly that, without expanding scope, without increasing costs, and without compromising safety. This bill is straightforward. It provides appropriate regulation. It supports hospitals, and it improves access. I want to thank everyone for the opportunity to speak, and I will appreciate your respectful support for House Bill 4832. Thank you.
Mr. Chairman and members of the committee, Thank you for the opportunity to speak here today in strong support of licensure for certified anesthesiologist assistants. I trained for nearly a decade to become a medical doctor and to specialize in providing safe, expert anesthesia care for complex open heart surgeries. The safety and quality of care delivered to the patients that I serve is paramount to my daily practice. Every day, I work both by providing direct care and by directing care in the anesthesia care team model. In my care teams, I've had the privilege of working with a multitude of vigilant, dedicated CRNA and CAA teammates. By working together, we're able to leverage our skills and expand patients' access to high-quality, safe anesthesia care. My group in Grand Rapids has employed CRNAs and CAAs since 1988, and I have medically directed CAAs for all the years that I've been practicing anesthesia. The bill under consideration by this body is critical for helping Michigan to continue building a stable, collaborative, cohesive workforce that allows physician anesthesiologists to lead care efficiently while ensuring patient safety. The CEAs that I have interacted with have consistently performed with high levels of professionalism and care. I am completely confident in their education, training, and clinical judgment, and endorse their position as a highly skilled advanced practice providers who practice as part of a physician-led anesthesia care team. The anesthesia care team model is the safest and most cost-effective way to deliver physician-led anesthesia services. It improves access to surgery, supports rural and community hospitals, and allows us to meet a growing procedural demand without compromising care. In a time of national shortages of qualified anesthesia providers, Michigan healthcare would benefit greatly from incorporating more of our CAA colleagues throughout the state to help reduce strain on our workforce shortages and to make Michigan competitive with our surrounding states that already offer full licensure. I'm honored to be invited to speak here today, and I respectfully urge all of you to support licensure for certified anesthesiologist assistants for patient safety, for physician-led care, and for the future of anesthesia services in our state. Thank you.
Thank you very much. Representative Tisdale.
Thank you, Chair. Thank you, gentlemen. I just want to focus in on, you used the term leveraging advanced practice providers, physician extenders, whatever term. So what is the different application or leveraging implications or applications between a CRNA and a CAA?
Well, in our anesthesia care team model, I can utilize both CRNA and CAA teammates in a 4-to-1 ratio as discussed. So as opposed to me sitting in an operating room for the entirety of the case, from induction, maintenance, into emergence or waking up, I can now oversee 4 of my teammates to kind of leverage those operations. So I can kind of be in 4 places at once while being physically present for critical moments of each procedure. So you can turn the skill set and knowledge base of one anesthesiologist to oversee potentially complexities or problems that might encounter in 4 operating rooms, also relying on the maintenance of those qualified personnel in the room, the CAAs and the CRNAs, who stay with the patient the entire time. So you can really expand your capacity to allow doctors to be involved in these operating rooms without having doctors sit for the entire time in every single room. If that makes sense.
And I've understood that as the application of CRNAs for some time. So you're saying that they're interchangeable?
In my experience, that everyone I've worked with, I see the same level of medical performance, understanding of pharmacology, physiology, and anesthetic care.
Do the rules make them interchangeable?
The rules make them interchangeable in the anesthesia care team model under a physician-led care.
Okay, thank you.
Representative Frisbee.
Just a question about the training and the length of time and in comparison of CRNA versus AA, if you can address that in like a thumbnail sketch for me.
Sure. CAA programs are either 24 to 28 months. They're a master's level degree. They require, the prerequisites require everything you would take to go to medical school, interchangeable with the MCAT or the GRE. Those are sort of the education pieces. I don't necessarily want to speak to the nurse anesthetists.
Sure.
They were a master's degree. They're now a DMP in the last 3 years.
Okay.
Does that answer your question?
Yeah. Yep. Thank you.
Yeah.
Representative Thompson.
Thank you, gentlemen. I think everyone's trying to wrap their head around what exactly a certified anesthetist assistant does versus what a CRNA does. Sure. Is there anything different that they do in the OR room?
In the operating room, they serve the same functional capacity. So if you want to think of a pilot and a co-pilot, if I'm the pilot, my co-pilot teammate, whether they be a CAA or a CRNA, can perform the same tasks in the operating room. Together, we can induce general anesthesia, provide a secure airway, maintain blood pressure, and keep a patient safe and safely anesthetized throughout a whole case. And then they can wake up and safely get them to a recovery area, whether that co-pilot be a CAA or a CRNA. The difference is their educational background. One of them comes from a career in education and nursing, and then extended study with a graduate level specializing in anesthesia. And our CAA colleagues come from a more general undergraduate background and then take an intensive multi-year focus in anesthesia, ultimately coming out to the same pathway to perform the same job. But they're just currently not licensed in every single state, but they have been practicing safely in Michigan for many, many years. And so this licensure would essentially make it easier and reduce the impedance to employing these folks throughout the rest of the state without all the legislative red tape, as it were, I think, as I understand it, with the delegatory authority.
Yeah, there are a lot of excuse me, there are a lot of hospitals interested in hiring AAs, but they want these providers to be licensed.
Okay.
Being the only unlicensed provider providing this type of care is not appropriate.
What would you say if someone were to tell you that a anesthetist assistant is just a glorified surgical tech? What would your response be to that?
I would say to come sit with me every day in the operating room. I've been practicing for 18 years. I know that I can do everything in the operating room that a nurse anesthetist can do, except that it's a patient's life on the table, so when something happens, I'm going to call anyone that's available to come in. Extra hands, extra eyes. We work as a team. We think the same. We're trained the same direction in the medical profession.
Oh, thank you very
And
much.
if someone posed that question to me, I would just use that opportunity to obviously provide a little bit more context as to if they're glorified surgical tech. That is obviously not a correct representative of what my colleagues do every single day, and I would love to give them that context and education of the difference of their skill sets. And yeah, so I agree with everything you said.
Thank you.
Yeah, thank you, gentlemen.
Representative Bierlein.
Thank you, Mr. Chair. I just want to clarify, so we do nothing changes. Like, we're talking about licensure, but if we do nothing, current practice in the state of Michigan, nothing changes. You're still able to use CRNAs and AAs in your ORs under your current model. If we don't license, like, nothing would change. So this is currently happening right now in the state under all legal guidelines.
As far as I'm aware, it is happening in a very small scale in Michigan. You said we have 30
There's only 30 AAs here.
practicing AAs. I trained in Florida, University of Florida, for residency and fellowship and practice there, and they have statewide licensure there, and so they are ubiquitous throughout the state. So the goal of this bill, so yes, nothing necessarily would change if this bill does not move forward, which unfortunately would not change our ability to provide qualified anesthesia providers to the rest of the state. So many places throughout the state want a solution to their workforce anesthesia shortages, and qualified CAAs, which are legal in 20 states of the union and 24 other places.
24 jurisdictions.
24 jurisdictions already, including our surrounding states of Wisconsin, Ohio, and Indiana. They have full ability to practice anywhere in those states, and we've been using them in Grand Rapids because we've gone through, as I understand, I wasn't around for the creation of this, but there's a lot more hoops to jump through in securing that workforce to to be a part of our company. So if they were fully licensed, the ability to apply them throughout the state would be much more great.
It's also a recruitment tool. When I moved here, I had to give up my license to come work here. So not having some piece of paper that says that this group can't just change their mind, and that means I can't go work at another place. Like, I want that piece of paper that says I'm licensed in the state of Michigan. I was licensed in DC, I was licensed in Georgia, and it is a barrier to having people to come into the state or come back.
Thank you. Representative Foreman. Answered. Very good. I had one other question. If you could, and maybe you don't have these numbers, but if we could dig them up, and maybe somebody that's coming up in a minute could. I see in Wisconsin, Ohio, and Indiana, they're practicing. Do you know how many practicing AAs they have in each one of those states?
I have it not in front of me. I know there's about 250, I believe, in Ohio, but I can get you those numbers afterwards.
Okay, that would be greatly appreciated. And I know I'll have some questions for the CNRAs when they come up on the similar side of this. So, any other questions from the committee? Seeing none at this time, I want to thank both of you for taking time and being here, and I'm sure you're sticking around. So we thank you, and if there's any more questions, we'll call you back up. Appreciate you being here.
Thank you.
Next up, we have Gina Welch, DRAPCRNA, Michigan Association of Nurse Anesthesiologists. I thank you for being here. I think you've been through this drill a couple times with me. Whenever you're ready, if you can press that red button, and the testimony table is yours.
Good morning, everyone. Chair Vanderwall and committee members, my name is Gina Welch, and I'm a certified registered nurse anesthetist, director of the University of Michigan Flint Nurse Anesthesia Program, and the current president of the Michigan Association of Nurse Anesthetists. MANA represents the nearly 3,000 CRNAs and student CRNAs who live and work in Michigan. Thank you for the opportunity to present testimony to the committee so that we can share our concerns in opposition to House Bill 4832. Currently, anesthesia care is safely provided in Michigan by either CRNAs or anesthesiologists. If approved, House Bill 4832 would recognize a new type of anesthesia provider called anesthesiologist assistants, or AAs. There are 4 reasons MANA believes that you should oppose this bill. 1, AAs do not improve access to care in Michigan. 2, AAs reduce the clinical training capacity for CRNA students enrolled in Michigan's 5 nurse anesthesia educational programs. AAs are an unproven anesthesia provider. There is no peer-reviewed studies that prove the safety of AAs. And 4, AAs have the potential to have a negative economic impact on healthcare in Michigan. First, AAs do not improve access to care. AAs can only practice when there's an anesthesiologist physically present to supervise them. Because AAs cannot practice without anesthesiologist supervision, AAs do not practice in rural areas where CRNAs are and practice independently. I provided a map for you that shows AAs only working in a few counties in our state, several of which include and surround urban areas. If for any reason the AA's supervising anesthesiologist is not available, the AA may not provide anesthesia care. Therefore, AAs and CRNAs are not interchangeable, despite what supporters of this bill have suggested. Nothing could be further from the truth. CRNAs have been providing full-service, safe, cost-effective anesthesia care for over 150 years. CRNAs provide anesthesia anywhere it's needed, in both our rural and urban areas. CRNAs practice in every setting, including hospital surgical suites, obstetrical delivery rooms, critical access hospitals, ambulatory surgical centers, the offices of dentists, podiatrists, ophthalmologists, plastic surgeons, and other medical professionals, and in our U.S. military and Veterans Administration healthcare facilities. In the majority of rural areas in Michigan, CRNAs working without an anesthesiologist involvement are the primary providers of anesthesia care. The inflexible AA anesthesiologist model of practice fails to adequately meet the needs of patients, healthcare providers, and healthcare facilities, especially in our rural areas of Michigan. The second issue directly impacts the more than 420 student CRNAs training in Michigan. Michigan has five outstanding CRNA programs that collectively have increased their number of graduates over the past 10 years and are continuing to increase enrollment to meet the state's anesthesia workforce needs. The programs graduate over 125 CRNAs annually, and of these graduates, approximately 97 stay in Michigan after graduation and work as CRNAs. These programs prepare graduates to function in the full scope of anesthesia practice, including the ability to practice independently in rural and underserved areas. If AAs are licensed in Michigan, our 5 nurse anesthesia educational programs will have a reduced number of clinical sites and placements available to train CRNAs. Because AAs are not permitted to train CRNAs per the accreditation guidelines of our CRNA programs. This decrease in training capacity will ultimately result in a decreased number of CRNAs practicing in our state, which will have a disproportionate negative impact on our rural and underserved patients. Third, AAs are an unproven provider. They have a limited history as anesthesia providers, and their numbers are too small to track safety or efficacy. The one study that was already referenced, the Stanford study, sometimes referred to as the SUN study, that is cited has significant limitations, including a restricted study population and lack of anesthesia-specific outcomes. There are no other peer-reviewed studies in the scientific journals published regarding quality of care of AA practice or AA anesthesia outcomes. The quality of care that AAs provide is unproven, and there's no meaningful research data concerning AA anesthesia safety. In contrast, the excellent, safe anesthesia care that CRNAs provide and associated anesthesia outcomes have been repeatedly demonstrated in peer-reviewed studies published in prominent journals. Lastly, MANA has serious concerns about AA's impact on healthcare costs. Because an anesthesiologist must be physically present to directly supervise AAs, 2 providers must always be involved when an AA practices. 2 healthcare providers, a supervising anesthesiologist and AA, must be utilized to provide anesthesia care to 1 patient. Independent studies have shown that CRNAs acting as the sole anesthesia provider is the most cost-effective model for anesthesia delivery. This model is used in many of our hospitals in rural communities and in many of our critical access hospitals. These facilities cannot financially sustain the cost of anesthesia services when the redundant AA anesthesiologist model, requiring 2 providers for each patient receiving anesthesia, is used. There are approximately 40 AAs, and I think we heard with the last testimony that the number is closer to 30 in Michigan, just 30. And nationally, there's about 4,382 AAs. Compare that to the over 2,500 CRNAs in Michigan, our over 420 students, and the over 65,000 CRNAs in the United States. Each year, around 3,200 new CRNAs enter the workforce in the United States, graduating from our accredited nurse anesthesia programs. This nearly matches the total number of AAs nationwide. In contrast, only about 300 AAs graduate annually. These numbers highlight the significant difference in workforce size and availability when comparing AAs to CRNAs. If Michigan demands more anesthesia providers, then our great state must support its existing high-quality nurse anesthesia programs and anesthesiologist residencies, not licensure for a narrowly trained provider offering very limited usefulness to Michigan citizens that decreases training capacity for our CRNA students. MANA appreciates the opportunity to weigh in on this important issue. We ask that you oppose House Bill 4832. Thank you, and I'll try to answer any questions that you may have.
Questions from the committee? Representative Tisdale.
I'm still, and it might just be me, maybe it's too early in the morning. You used the term, or the phrase, physically present. And so I'm trying to understand what that means. Does an anesthesiologist have to be physically present in the room, on the OR floor, on the premises, on site, and how do you translate physically present and monitoring 4 rooms?
So that's a great question, and hopefully I can answer it a little more clearly for you. So physically present,
Well,
certainly.
I've been struggling so far, so you might not succeed.
Well, let me know if you have any follow-up to my answer. So when we talk about medical direction, whether we're talking about AA medical direction or CRNA medical direction, we're really talking about being physically present in the facility, one, of course, but also being physically present for what are considered the most technically difficult aspects of the case. And there are 7 rules that need to be met. They're called the tougher rules. And there's a body of research that talks about when A's are supervised, even at a 3-to-1 ratio, that in the vast majority of cases, those rules are not met. So yes, they are required to be physically present at certain times and actually directing the care under that medical direction. And that is the way that they're trained and utilized. CRNAs may be trained and utilized in that way. Well, we're trained well beyond that to practice independently and in the full scope of anesthesia care. However, we can be utilized in that care team model under medical direction, but we can also practice independently. So for example, let's say there's a major issue and all the anesthesiologists at a facility that CRNAs practice at, and there are no anesthesiologists for there some reason today. All of the CRNAs can still continue to practice and completely execute all the anesthetic care, as long as the hospital bylaws allow for that. If that same institution was staffed by AAs, not a single anesthetic could be given without anesthesiologists physically present and able to supervise and direct care. Did that answer your question, Rep. Tisdale?
That's getting much closer. Thank you.
Representative Foreman.
Thank you. This question may not be directed for you. It might actually be for Rep. Preston, but I'm curious about the impact of, so the previous people told us it's only 30 people in Michigan, maybe 4,400 nationwide. Our surrounding states are doing this. But however, what would be the impact on licensing through our departments? Like, what does the procedure, I may have missed this, but what does the procedure of licensing look like? Because to me, it sounds like there's a gap in training, maybe, and I'm just missing something like Rep. Tisdale. It is also very early and I'm undercaffeinated.
I can't answer the question about the process of licensure at the state level, certainly, but I can talk to you about the difference in education. So AAs can have an education in anything. Any one of you could become an AA, with whatever your educational background is at this moment in time. So what you'd have to do is take the prerequisite courses that are required, and they're similar to what, as previously testified, similar to the science courses required as prerequisites for medical education. And then they go through a master's level program that varies from 24, I believe, previously testified, to 28 months, and they have about 2,000 to 2,500 clinical hours. With CRNAs, we are nurses first. And so we have all the education and training of a bachelor's prepared nurse or an appropriate biological science degree. And so while we may not have the same exact science courses as medical school prerequisites, we have the same science-based courses. We have chemistry, organic chemistry, biochemistry, all of those courses, pathophysiology, anatomy and physiology, et cetera, coming into our profession as nurses. Then we are required to spend at least 1 year taking care of the absolute most critical patients in the hospital in the ICU. So we get the experience of hemodynamically monitoring, intervening, pharmaceutical administration, all of those things that you get as a nurse, taking care of, again, the most critical patients. And that type of care prepares them for that clinical transition into CRNA school, where we are taking care of the most unstable and most vulnerable patients under anesthetic. And then our educational programs are doctoral. They're on average 36 months, some go up to 40 months, doctoral level. And then our students have almost 10,000 clinical hours in comparison. And then we have the ability, and we are trained to practice within the full scope of anesthesia. So if you think about another type of advanced practice provider, for example, a nurse midwife. A nurse midwife can provide much care along the continuum, but if the patient ultimately were to need a C-section, let's say, a physician would step in. But within the scope of anesthesia practice, CRNAs can do everything and have the full scope of practice, education, and training to allow us to function independently, just like the anesthesiologists are able to do. And that's why we're able to practice independently and have full scope of practice and licensure here in Michigan. You're welcome.
Representative Thompson.
Thank you. This may sound silly too, but then why don't we just put the anesthesiologist assistants under the CRNAs? If you're able to practice independently, why couldn't we utilize your position in the healthcare setting and have them work under you so that we just had greater access if that's what the issue is?
That's a great question, and that would certainly be a solution. That would help solve this problem. There is no billing code to allow for that at this time, but that is certainly something that both our state association and national association support as a solution to this shortage. And again, there are not many AAs compared to CRNAs, but we certainly would be willing to step in and assist with the shortage and supervise in that role, because again, we have the training, we have the education, and we have the ability to practice within the full scope.
Thank you.
Representative DeBoer.
Can you compare the education for me of the AAs and the CRNAs if they're interchangeable? That you can be independent, then do you have the same education?
We don't have the same education. Yeah, we don't have the same education. We're not trained in the same fashion. We're not trained to work in an assistant role. We're trained to work in and educated in a full scope of practice. So there's quite a bit of difference in our training.
But you would be qualified to do the same thing the AA does in supervising the CAAs?
No. I could supervise in the same role as the anesthesiologist. Yes.
Yeah. Even though your training's not the same?
As an anesthesiologist?
Yeah, that's my question.
Oh, I see. I'm sorry. I thought you were asking about the AA training versus the CRNA training. I apologize.
Yeah,
That's okay.
Wrong acronyms, probably.
Right.
Sorry.
It's okay. There's lots of acronyms.
I know I come out of education, not medicine, so thank you.
Yes, of course. So we do not have the same education. Obviously, they're physicians first. We're nurses. They go to medical school and then go through residency. We become nurses, get clinical experience as nurses, and then go into a doctoral program. So both of us have what's considered a terminal practice doctorate. So even though we don't have the same exact training and background, and they have more training in general medical education than our training is very specific in anesthesia. But we are still able to function within the full scope of anesthesia practice, and we can practice independently within that anesthesia role. So we could certainly step into the role of supervising AAs if that were something that was identified as a way to help alleviate this shortage. But the way it's structured now with, especially in our rural areas, the rural facilities certainly they just couldn't afford an anesthesiologist being supervised by AAs, and that's why they predominantly utilize independent practice CRNAs.
So could we shift that same line of reasoning to justify CAAs then? But
within the care team model, we can be utilized in the same way. So when you talk about us being interchangeable, or someone talks about us being interchangeable, within the care team model, yes, we are utilized in the same way. But CRNAs can be utilized in a much more expanded way. And whether the facility chooses to do that or not is ultimately up to that facility, but they certainly could. So for example, in that care team model, where we have one physician anesthesiologist overseeing 4 CRNAs, so we can do 4 anesthetics. If the anesthesiologist stopped supervising and started giving anesthesia directly and allowed the CRNAs to practice independently as well, 5 patients would get anesthesia. You can never do that with AAs. They always have to be supervised.
Yes, I see that. Okay, thank you.
Of course.
Representative Bierlein.
Thank you, Mr. Chair. Clarification. So I thought that all nurses, no matter level, still had to operate under kind of the managed care team. So there is a supervising physician somewhere in this mix, whether it's a contractual or so. When you say operate independently, can you just go to a hospital and operate outside of that that care model or that managed practice care model?
We always give anesthesia in coordination with a physician or proceduralist, right? We don't just give anesthesia, in a tattoo parlor or,
No,
something like that.
I understand that.
So-
It sounds like the NPs would be really jealous of the position you're in.
So,
because
yes.
you have what they're trying to get,
Right.
or am
They
I
are-
missing
they are-
something?
We have what they're trying to get. So within the perioperative course, we are fully independent practicing. We do not need a collaborative. We always work in collaboration. Of course, we have a collaborating physician always, but there's no contractual agreement. And that's because there's always someone doing something to necessitate the anesthesia. So a proceduralist, a plastic surgeon, a dentist, a surgeon, etc. There's always an interaction, certainly at that level. But there's no one, when a CRNA practices independently, they're practicing under their own license, and no one else has any liability, medical liability, for the decisions or care of the nurse anesthetist.
Okay, thank you.
Yeah.
Thank you. I'll finish up on questions real quick. Right now, you said you have 5 schools, is that correct?
Correct.
How many openings do you have in each one of those schools right now, or you have a waiting list?
0 waiting lists. We have between 200 and 500 applications for each program for the seats that we have. And my program is the largest program, and we're going to see our largest cohort coming into this next semester of 38 student CRNAs. So.
Very good, thank you. All right, well, thank you very much for your testimony. We appreciate it, and we look forward to working with you on this bill. Next up, coming up together is Eric Riley, Michigan Society of Anesthesiologists, and Dr. Tom George. How are you, sir? And Michigan State Medical Society. Thank you both for being here, and we appreciate it. And whenever you're ready, the testimony table is yours.
Mr. Chairman, members of the committee, thank you for the opportunity to speak today. My name is Eric Riley. I'm an anesthesiologist practicing here in Michigan, and I'm speaking on behalf of the Michigan Society of Anesthesiologists. We support the licensure of certified anesthesiologist assistants in our state. Real quickly, after the previous testimonies, I just want to give a brief rebuttal. Our nursing colleagues, they present physician-led care as a bad thing. I think common sense can determine that care from a physician is not a bad thing. I would warn caution against blindly accepting some of the data presented by our nurse colleagues. I know these cited articles, and many are from low-tier journals or op-eds, with impact factors near 0, which is similar to a Sports Illustrated. Furthermore, most of the data is grossly extrapolated, such as counting a CRNA's rural home address as counting as rural work, when we know many of them commute. Rep. Thompson, earlier you asked, why is licensure or delegation important? When it comes to delegation without licensure, you create legal battles. Hospitals prefer clear licensing boards with defined scope. There can be credentialing friction and liability ambiguity. You can have increased malpractice premiums and increased credentialing friction, which often hinders these institutions from hiring CAAs without a license. Rep. Tisdale, I hope that I can answer your question. Immediately available means within the facility. Anesthesiologists may handle other pertinent matters, similar to a rounding physician who may have PAs or NPs. They may, as the physician, I may be seeing one patient, but I can be immediately available when something urgent comes up. I'm always in the facility. Rep. Bierlein, you mentioned the scope law. According to Michigan law, even CRNAs must collaboratively participate in a patient-centered care team. That is straight from the law. This is further defined in the law that the patient-centered care team must include a qualified physician or dentist who has specialized in anesthesia care. By definition of Michigan law, CRNAs cannot work without physician collaboration. I think I hit everyone. Going back to my initial testimony, I serve on one of the 5 liver transplant teams in Michigan. I participate in international surgical missions, and I've worked alongside both CRNAs and CAAs to treat underserved patients across Michigan. Those experiences made something very clear. Access to safe, physician-led anesthesia care saves lives. Expanding our care teams responsibly augments that life-saving footprint. CAA licensure is one such path. At its core, this bill is about ensuring consistent high standards of care for patients across Michigan. Licensure is critical to standardized qualifications, training, and accountability in healthcare. Whether a patient enters a hospital in Detroit, Ludington, Iron Mountain, or anywhere in between, they deserve the same confidence that the professionals caring for them meet uniform statewide standards. Licensing CAAs helps ensure consistency and reinforces the quality and safety patients expect when they seek medical care in Michigan. As referenced earlier, CAAs are already working within several medical centers throughout our state. They simply lack licensure. Meanwhile, our neighboring states, Ohio, Indiana, Wisconsin, there are 342 CAAs in Ohio, 91 in Indiana, and 153 working in Wisconsin. They already see the value. They have licensed CAAs working in physician-led care teams at the Cleveland Clinic, Case Western Reserve, Ohio State University, and Indiana University. The discretion of such esteemed institutions should not be taken lightly. They know what we know. CAAs are safe and effective. Licensure would also create meaningful economic opportunities for our state. Establishing a clear professional pathway opens the door for new healthcare jobs and the potential development of CAA educational programs within Michigan's universities and medical centers. Instead of sending talent elsewhere, we could train and retain highly skilled professionals right here at home. Licensing CAAs is a practical, proven step that strengthens patient safety, supports our healthcare workforce, and improves access to care across Michigan. Thank you again for your time and your consideration.
Thank you, Mr. Chair, and thank you, Preston, for bringing this important issue before us. It's one that's, we actually worked on and off at it for a decade or so. We've looked at it, but the timing is really important because we do face wide shortages, across the spectrum in healthcare. By the way, I'm Tom George. I'm the CEO of the Michigan State Medical Society. We represent all physicians, but I happen to be an anesthesiologist, so I have a personal, interest in this and some experience in the anesthesia care team, 40 years worth. In our anesthesia care teams in Southwest Michigan, where I practiced, we did not have CAAs specifically because they weren't licensed. Our group was afraid to hire them, and they were fearful of the process of getting them qualified at the hospital. There's one other barrier, too, and this comes to a question that Representative Thompson asked earlier. Another value of licensure is that the Michigan Supreme Court ruled a few years ago that if you're an unlicensed healthcare practitioner, you do not benefit from Michigan's medical liability reforms. So the caps on damages, the statute of limitations, none of those things apply to an unlicensed healthcare provider. So it's an impediment to hiring. An institution or a practice like ours will look at that and just makes it that much more difficult to bring them in your community. A couple things I want to touch on, too. The critical access hospital issue. The shortages are not just in critical access hospitals. They're also in metropolitan areas in anesthesia. And it affects, the flow of all of healthcare if your surgery's delayed or put off because there's not anesthesia providers. And that's happened in Michigan. We've had shortages so that people's surgeries have actually had to be postponed. In our practice, we did send an anesthesia care team to 2 area critical access hospitals. One was Lakeview Hospital in Paw Paw, and the other was Pennock Hospital in Hastings. And we sent a team with an anesthesiologist almost daily with 2 to 4 nurse anesthetists. And that would be a perfect setting where we could send a CAA. If we had them. So it's not true to say that they won't make a difference, in critical access hospitals. There are critical access hospitals that use anesthesia care teams where they could step in. Another benefit of licensing is the question of safety came up. What about the safety issue? Well, without licensing, you won't know. You can look up my license right now, or the nurse anesthetist who've testified. You can look them up on the LARA website, and you can see if there's an investigation or what the status of the license is. There's no mechanism like that for the CAAs. So it is a public health matter. They're giving anesthesia here in Michigan. They should be licensed so that there is a mechanism, to oversee and to monitor and for the public to make complaints. So I think I've touched on the main issues that I wanted to make. I want you to know that the medical society, the broad swath of physicians, all specialties support this bill. As Rep. Preston says, it is an incremental but important step to relieving some of our healthcare shortages in our state. Thank you.
Thank you. Any questions from the committee? I'm seeing no questions from the committee. I guess kind of goes back in. There was a comment that I noted. 1978, the state of Michigan allowed AAs to start practicing here in the state of Michigan, and there was a statement that was made during testimony that this would be a financial impact to the state of Michigan if we allowed AAs to be licensed. Is there anything that you can add to that?
Sure, I'll elaborate. As far as credentialing goes, creation of a board and those methods are usually covered by the licensing fees. There's payment parity in anesthesia reimbursement. That means that reimbursement is the same regardless of who provides anesthesia care, whether that's anesthesiologist only, medically directed CAA or CRNA, or CRNA supervised by a surgeon in rare instances. Thus, introducing CAAs is cost neutral from a fee perspective. On the contrary, CAAs guarantee anesthesiologist-led care, which some data suggests can reduce downstream costs by lowering complications, unexpected dispositions, unnecessary testing, and surgical cancellations. So that is
Thank you. Any other questions? Representative Bierlein.
Not sure if this would be a question for you or Rep. Preston. Will there be continuing education that would be required as a result, and what are those units per 3 years, 2 years?
Is it 50 over 2?
I think the national standard is 50 credits in 2 years, 25 a year is the national standard now.
Which I'm a little bit jealous of because us paramedics have to do 70 over 2 years.
You want to talk about 132 over here?
All right, Representative Foreman. Or excuse me, Representative Frisbee. I'm sorry, I saw the.
Thank you, Chair. What are the
I wanted to shock you is what I wanted to do. I'm kidding.
What are the current CE requirements for CRNA?
I don't know the current requirements. I'll defer that to my CRNA colleagues.
Okay. Anybody?
Every 4 years, as well as ongoing assessment.
Okay, thank you.
Very good. I want to say thank you to both of you for taking the time and being here today. We have one more card wanting to speak in support of the bill. Teresa Bacon Bagley from Grand Valley State University. Thank you, Teresa, for being here today. Pardon?
I'm just looking at who's speaking, so.
Right here.
There,
Thank
okay,
you.
great. So push the button.
Yes, push the button and the testimony table is yours.
I am Teresa Bacon Bagley. I am one of the associate deans in the College of Health Professions at Grand Valley State University. We have 21 programs. We don't have a medical school, but most of our 21 programs are licensed professional programs. I was going to talk a little bit about what Dr. George said about licensure and why it's important. But he stole my thunder. So I'd like you just kind of rewind a little bit about why that's important. It's a public health issue. The public needs to know the qualifications. They need to know the scope of practice. They need to look up their providers. They should have the right to do that. So licensure is extremely important. Of our 21 programs at Grand Valley, We do have a physician assistant program. We do have a nurse practitioner program. So we are very much like the other institutions that are present here. We have seen this battle between two professions where their practice is overlapping. And that shouldn't stop the two programs here from existing in the state of Michigan, the CRNAs and the CAAs. I am a nurse, so I am supportive of all healthcare practitioners. We have a shortage. Our community members are coming to us as educational institutions to solve problems. Licensure would help our educational institutions in developing programs that have the ability to have licensure so that they can practice in the state of Michigan. The anesthesiologist assistant programs are here to stay. 1969 was the first one at Emory University. Since then, we now have, according to the accrediting body, 25 programs in the United States. They are here to stay. And so I think it'll do the citizens of this state a service to have licensure of a healthcare provider that is able to meet the needs of the community. So I will take any questions.
Any questions from anybody on the committee? Seeing none, I want to say thank you for being here. Appreciate you. It was a beautiful day to take a drive over, that's for sure. So thank you for being here. I appreciate it. As we finish up, one other thing, just so I know there's a couple people that wanted to look it up. 2021, it was Public Act 23. When I served in the Senate, that we worked very closely with the Public Act 53, right? That we worked very closely with the expansion with the CRNAs, so I do appreciate their hard work and what they've done. But just for anybody that wants to read what that bill was signed into law, it was 2021 Public Act 53. So with that, Representative Foreman moves to excuse absent members. There being no objection, the motion prevails. There being no further business before the committee will stand adjourned.